Good afternoon, everybody. Thank you for attending today and joining us. The webinar will start shortly. Please be aware that it is recorded and will be shared publicly afterwards. So good afternoon. I think we can make a start. It's my greatest pleasure to be hosting the LEAP webinar today. The development and the publication of the 7 principles of practice-based learning by the Chartered Society of Physiotherapy and the Royal College of Occupational Therapy had provided opportunity to look at practice-based learning with a new lens. Practice is responding to changes in the UK, the aging, the growing population with more complexities than ever before. And alongside this, there's both policy drive and patient desire to person-centered care closer to home, care that is underpinned by a robust evidence-based practice. Equity is promoted and communities are empowered. The 4 pillars of practice: clinical, education, research, and leadership, professions are already recognizing their importance by firmly embedding the pillars within their robust career development framework. And practice-based learning should reflect this too. During our webinar today, we hope to provide you with these strategic and professional drivers for such placements and present to you how the undergraduate research placement was constructed, delivered, and evaluated at Hull University Teaching Hospital NHS Trust. The pre-placement preparation focus on the project, objectives, student, educator, evaluation, outcomes, and lessons learned. Finally, it presents recommendations for future placements of this type based off experience gained. We will be highlighting why this is important to our wider system at Humber and North Yorkshire Integrated Care Partnership, the ICP. There will be some time at the end of the webinar to take any questions you're posting in chat. And your mics and cameras will be enabled to raise these too. And if we run out of time, we will be collating all of these questions and make sure that they're answered and posted to you in our post-webinar communication around 2 weeks from today. My name is Hanan Harb. I'm one of the LEAP project managers holding the Working Together Differently portfolio in the LEAP team. LEAP team is hosted within the People Directorate at Humber and North Yorkshire Integrated Care Partnership. I'm delighted to introduce you today to my colleagues, Dr. Jane Anderson, who is the Allied Health Professional Practice Development Lead at the Hull University Teaching Hospital, and had the role of the practice educator physiotherapist in this shared journey. Alongside Jane, we will be hearing also from David, who unfortunately today had technical problems with his camera. So I'm glad that he's got the picture so you can visualize him, who's a former student at York St. John University and currently working as a musculoskeletal physiotherapist at Cambridgeshire Community Service Trust. Contact details for all of us are included later in the slide deck, should you wish to get in touch, including hyperlink to our Twitter and future NHS platform. Please do tweet us. Accounts are all in the slides, and share information about anything that stands out for you today. We would love to hear from you. Before I provide you with a brief overview of the LEAP program, I thought it would be helpful to clarify the role of integrated care system and why this is a strategic importance to us. Apologies to those attending who are already familiar with integrated system, as referred as ICS. Our health and care systems are a partnership of organizations that come together to plan and deliver joined up health and care services and work together to improve the lives of people who live and work in this area. Humber North Yorkshire and Care Partnership are one of the 42 statutory health and care systems now established across England. We are one of the 4 ICSs within North East Yorkshire region, and we have 6 places within our geographical footprints. The Humber North Yorkshire Health and Care Partnership have published their integrated care, health and care strategy, and these slides outline our ongoing ambition to improve the lives of our residents and to increase their life expectancy. It is underpinned by health foundation building blocks of good health. Our vision is for all people to start well, live well, age well, and die well. And we have set an intention to achieve this vision with focusing on creating the right conditions within our ICS that will change and empower and enable our residents to think person, think family, and think community. Think person as enabling people to live healthy, independent, and safe lives for as long as possible, understanding what matters to them rather than what is the matter with you. Think family and supporting families to enable everyone to be safe, grow, and learn, and that every child has the best start in life. Think community by being all inclusive through community approach that ensure that the next generation is healthier than the last and have the opportunity to thrive. So LEAP stands for Learning Environment Assessment and Placement. It is part of the NHS England programme established within Humber in North Yorkshire since 2020. NHS England's main aim originally was to increase practice-based learning opportunities for pre-registered learners in order to meet the national workforce ambition. Despite this, our stakeholders agreed at the start of this program that an increase in practice-based learning opportunity would likely to be an incidental output of the project. This is because placement expansion is more complex than just opening new and learning spaces. This allows us to adapt our strategy, and ambition has always been to fund and develop interventions for any learner, and to also to make sure that our existing workforce were included within the definition of a learner. We have the LEAP strategy and delivery plan. We are supporting the delivery of 3 strategic priorities and 5 objectives outlined on this slide. Our priorities are all based on the call to action within NHS People Plan for grow our workforce, train our people, and work together differently. The LEAP program is effectively an enabler, providing funding for proof of concept pilots that can be sustained and reproduced at scale beyond the life of LEAP. You can find out more about the program by following the links to our web pages and our future NHS platform. For now, however, I'm delighted to hand over to Jane and David to share information about their delivery of research placement.
Thank you, Hanan, and good afternoon, everybody. Yep, my name is Jane Anderson. I'm HP Practice Development Lead at HUS, and I am delighted to have David with us today as well to give his reflections actually on the research placement. Next slide, please, Hanan. So the NHS Long-Term Workforce Plan highlights really the increase, quite alarmingly really, in education and training numbers up to a projected maximum in about 2030, 2031 in numbers of staff for all healthcare professions to respond to the increasing demands on our healthcare system. Next slide, please. So this is also taken from the NHS Long-Term Workforce Plan as well, just to give you an idea of the gravity of the numbers really. So at the moment, there's just short of 30,000 nurses in the workforce. And in 2031, we just want that to rise it to 54,000. So a huge increase. For AHPs, there's roughly about 15,000 in the workforce at the moment. This is projected to rise to nearly 19,000 by 2030-31. Now, of course, the increase in training placements within HEI means an increase in demand for practice-based placements in places that we're already working at full capacity with many demands. But there is a requirement to explore how we as placement providers can rise to that challenge of increasing placement capacity whilst also maintaining the health and well-being of our staff. Next slide, please, Sandra. So the 4 pillars of practice used to be called the 4 pillars of advanced professional practice. But now there's a real realization that the 4 pillars should receive attention right from the get-go, really, including our undergraduates. This also permits us the opportunity to expand our placement bases, so assisting students to gain invaluable experience across all 4 pillars in the very early stages of their career. And these include leadership, if you want to click, and research. Thank you. The role emerging placement I think is particularly exciting because it ticks all 4 pillars for me. So 2 more clicks, Hanan, please. It explores areas where professions may not usually be represented, educating those who the students are working with about their professional roles and what they can bring to that particular working environment, and building those relationships, championing as leaders new ways of working and evaluating the results of that placement and the effect that they've brought to that particular learning environment. Next slide, please. But for today, though, we return to predominantly the research pillar to share with you some of our reflections from a research placement we delivered at HUS in December 2021. And I am delighted to say that we're joined here by David today, who was our first student to undertake that research placement here with us at HUS, who is now a qualified physiotherapist. Next slide, please. So we were keen to pilot a research placement with the 2 main objectives, really. I'm going to talk more about the format and considerations for a research placement in terms of the organisation and delivery. So thanks, Hanan, for the introduction that you gave, but also give useful considerations and reflections, really. And obviously, David's going to recount his experiences as well. But that said, it is useful to give a little bit of a focus of what the placement covered as well. So our primary objective was to evaluate a new placement which primarily focused on research, audit or service evaluation. And our secondary objective was to create the additional placement capacity that was absolutely needed and increase the toolkit of available placements for students at HUS to facilitate learning. At the same time, a leadership placement was also run. They ran side by side, really, and that was led by Hanan, who's obviously here today with us. So not only were we able to trial a research placement, we were also able to trial a leadership placement as well. Next slide, please, Hanan. So basically, in terms of what we looked at, it's useful to give an idea, obviously, of the placement as well. We were so the focus of the research placement was looking at some data that we collected from our COVID-19 patients who had been hospitalised. One thing that we did notice when we first started to look at the data, which I think obviously David can touch on as well, is that we looked at the 3 waves of data from waves 1 to 3, so the 3 kind of surges in the pandemic, if you like. We looked at quality of life data across waves 1 and 2, and we also used 2 different outcome measures that measure quality of life, the EQ5D5L and the MRC breathlessness scale, which was automatically data that we collected for this. We did plan to look at waves 1 to 3 because what we wanted to do was basically look at the different strains of COVID-19 that were actually happening, just to see if the virus was attenuating and having less of an impact on quality of life data. But what David did notice as we started to look at this data was that the pre-COVID data had stopped being collected for wave 3. This was picked up quite early by David, and we were able to communicate with the relevant people who were actually kind of organising the pro formas that the patients that we were sort of following up afterwards. So this was changed, but unfortunately only meant that David could analyse waves 1 and 2. So we were very keen to have a look at the service evaluation, look at some statistical analysis, and just see if the virus was having less of an impact actually on patients, obviously, as the time went by. The planets aligned with David, really, because David, this literally was a placement that followed straight after David's first placement. And David actually worked with our respiratory outreach team. So it was so useful for David to actually come in, because this respiratory outreach team that they were working with actually were beginning to look after these patients who were having still sort of prolonged periods of problem respiratory wise. So it was quite useful for David to have that experience beforehand, and systems that in place for referral for those sorts of patients before he actually came into this research placement. That was more by luck than judgment, but it really did make a difference. Next slide, please. So this is quite a useful slide, I think, in terms of thinking of research placements in particular, really. What we wanted to do was do a project that would directly benefit our local population, so that we could understand the requirements service-wise, the effect that probably prolonged long COVID, for example, would have on our patients, and whether there was actually some attenuation in the virus and people were getting better and getting back to full fettle as quickly as possible, really. All of the patients that we actually looked at in the research placement were patients who had been admitted. So we're obviously the more poorlier COVID patients, really. It was important that we were able to have a research placement that lasted long enough, but didn't sort of only last 3 weeks. It had to last the duration of David's placement, which I'm going to let you know in a minute how long that was. It's not always a necessity for a research placement. It may be that you'll reach a final stage where another group of students can take over. But because this was our first placement, we were exploring the unknown, really. We decided that we would try and fit a start and a finish to the placement as much as we possibly could. We needed to make sure that any access to data was acceptable for students to access, and also for us to access as well, because we were working with some system partners with this. And obviously all the information governance was okay behind it as well. So David had quite a fair bit of mandatory training to complete in order to do that. We needed to make sure, because there was an element of research and audit to it, that there were no ethical concerns. And as mentioned, we had to make sure that the appropriate training was put into place. Delivery of the placement, it was important pre-placement that we had to think about the timetable and its organisation and the equipment that might be necessary in order to make the placement happen, especially if the placement wasn't always, as was the case, face-to-face actually within the hospital. Because of that, we had to make sure that David had access as much as possible to the Trust Patient Information System. So not only when he was in the hospital, so to speak, but also outside of the hospital as well. And we were very lucky in that respect, because David already had access, because he'd done this placement literally before with us. It was just a case of just contacting the relevant people in order to make sure that that was reactivated. In order to have a plan, we needed to make sure that we had the timetables in place. So we did pay quite a bit of attention to forward planning of meetings. So David and ourselves knew where we were with all the other responsibilities that we had as our normal day, really. We were really keen as well to embed some sort of a clinical element into the research placement, so it didn't become too dry, to make sure that, you know, that there was that clinical component, which of course is very important for our students. We do realise that. So next slide, please. So David was a physiotherapy student. He was an MSc student in year one, and this was going to be his second placement, and he was a student at York St John University. he did a full-time placement with us of 6 weeks, so 37.5 hours over 6 weeks. Next slide, please. So what I'm going to do now, if that's okay, David, is hand over to you just so that you could give a little bit of a student's, your own perspective really, and some reflections of the placement, if that's okay.
Of course, yes. Well, thank you, Jane and Hanan. So lovely to meet you all, everybody, if not so digitally. And sorry, my camera's not working today, so I'm afraid you don't get to see me. So yes, obviously Jane sort of giving the lowdown as to what was involved on the placement and all the many positives and facets to it. So having come from an academic background previously, having sort of done research and sort of being involved in the lecturing world as well. So I've been a mature student, sort of quite au fait with doing research, but never in within the NHS environment. And this was quite novel for me, and I think it actually opened up quite a lot of different appreciation to the application of research, which I think is fantastic. I think, especially from a student perspective, it opens up to appreciation of what you can do within the NHS through research and what sort of opportunities there are available. Now, so I'm working as a musculoskeletal outpatient physiotherapist, but I'm actually, funnily enough, today working on my research champion role. So I've taken on that role since becoming a physiotherapist and working within the NHS. And so sort of doing this has actually helped facilitate this placement has helped facilitate me attaining this role as well, and was a star position put in a star position from application of that internal role. I say it's in terms of reflecting back on it, I think it was actually a very enjoyable placement. It opened my eyes to, like I said, a different approach for research. It was also quite useful, like I said, being a mature student. It actually afforded me flexibility and ability to do some work from home as well, as Jane was alluding to, but it also gave me a clinical element. I know there can sometimes be a concern about with a research placement, especially when you're doing a placement to develop your clinical skills as a therapist. I saw quite that. So lots of tele-based health and sort of doing prescription, the exercise prescription referral on as well for management in the community, but also doing the assessments over the phone and actually finding the EQ5D, 5L ratings and the MRC breathlessness scale, and been able to then correlate that to sort of the patient's clinical outcomes was quite beneficial, I think, and it sort of gave me a different approach to managing patients, which for years I've had a hands-on experience, and talking to a person in front of you is very much different to talking to a patient over the phone. And I think it's very good for that sort of skill development with a soft skill sort of development. But yeah, so I think for me it was a very valuable experience, and I was very pleased I was afforded the opportunity, especially to be the first ever student. So poor Jane did very well having to me as her first student, and made it a really fantastic experience. And I think it was very positive coming out of the other side. It's always the nature when you're the first the first student going for a new placement. I think it'd be a bit daunting, but overall, I strongly recommend this, and definitely something worthwhile considering as an opportunity for students for you in the future. Yes, I'm sure I'll be happy to answer any questions later as well if anybody would like to ask me anything.
Brilliant, brilliant. Yeah, it's difficult not to give sort of, obviously the report of actually sort of the findings of the placement, but I think today it is more about the organisation of research placements really, and any useful tips that we can give really. Yeah, I mean, I think the it was very, very useful to have met David. I was a PLF, a practice learning facilitator at the time, so had very close involvement with students, and it was really through discussions with David, that we realised that there was this potential. So it's kind of between us, wasn't it, David, that we thought, we think we could put a research placement together here. So, you know,
I think it's on my first day, my first placement. I think I remember discussing it as you're taking me over to my first placement. And I think it was just kind of one of those opportune things.
No, absolutely. And I think sort of, you know, out of opportunities come possibilities, don't they? So as I say, the planets did align. It was so useful having had a placement, you know, straight after the research placement straight after an area that was so closely related, because you knew all of the rehab referrals that were needed. You knew them better than I did, you know, so it was very useful. But also to say, actually, in terms of the telehealth, we had fantastic support from Marion Nettleton, who was also part of the study team, the direct research team, who kind of took David under his wing. And it was kind of a see one, do one, teach one approach, wasn't it, David?
It was a slight baptism by fire with some patients, but it was definitely it was brilliant. And Marion did a fantastic job. She was very supportive, and I think that's the thing. You sort of, if you've got a good team around you, it makes it such an easy sort of placement style as well, I think, to carry out.
Yeah, definitely. So next slide, please, Hanan. So in terms of outcomes, obviously it was such a local study because we were looking at our local population, which we were absolutely delighted about, and obviously ticked a lot of boxes in terms of sort of looking after our own people, really. So very current, thinking about how we should be, you know, looking at our local population to see how we can best deliver healthcare. So we did gain that local knowledge of patient outcomes following hospitalisation of COVID-19, which we were able to share with the relevant people, which I'll talk about the stakeholders soon. As David mentioned, flexibility was great. With being a mature student, David had other responsibilities, which meant that he could actually really manage the placement around those responsibilities to very good effect, really. I mean, in saying that, David, you were actually in quite a bit, weren't you, as well? But also there was that opportunity because of the tech and because of the way that we were delivering the placement that David could actually work at home as well. Obviously,
Yeah,
we've created additional place. Sorry, David?
Sorry, beg your pardon. Sorry, Jay. Yeah, I was just saying, I think it afforded a good balance, and I think that's kind of, especially with sort of the workforce approach nowadays as well, for sort of trying to find balance and flexible working. I think it reflects that really well. Sorry.
Yeah, no, thanks. We were able to create additional placement capacity at a time where it was really very difficult for staff. I think it was December 2021, so we were just coming out, well, kind of still within the third wave, really, weren't we? But, you know, just moving out of it. You know, people were finding their feet again. There was still lots of uncertainty about COVID generally. But we were able to make sure that we could offer these extra placements without putting too much pressure on the staff in terms of their health and well-being. We were able to do a formal service evaluation. And so in terms of all the information that we needed to supply, we filled in a CG1 form. In fact, I say the royal we. I said David filled in a CG1 form that was also part of the requirement of the research placement to really take it from the beginning to the end with support. So he completed all the relevant information that he needed to go to the audit department to get the okay to be able to access the data in terms of clinical governance. We felt that was important rather than just giving them the doing stuff, really. The organisation from beginning to end we felt was very important, because it's not a full journey otherwise. So it is important that as much of a journey in terms of research from beginning to end is quite important. Attention to detail in data collection. We'd have never known for the third wave that we were not collecting pre-COVID data of quality of life for patients if David hadn't had a look at the data and said, I don't seem to be able to find the pre-data for our wave 3 patients. So the relevant communications happened, and now they were able to start collecting that, but not at a point, unfortunately, that David could actually look over the 3 waves to see on quality of life. But we did have the 2 waves. We had a full set for that. And the clinical component as well. We achieved the clinical component whilst it wasn't hands-on. We still had that level of clinical component where David had to make those decisions in order to signpost patients to various different methods of treatment, maybe pulmonary rehabilitation programs if that was necessary, based on his clinical judgment from interviewing the patient. It was a pro forma that was actually being completed, hence why David noticed for wave 3 that a bit was missing. But that was able to be put into motion and changed. Next slide, please. The other thing is that we're able to maintain service. I actually sort of supervised David during some of the sessions, but some members of our team were taking annual leave. So there was 1 week when there was nobody to do the telephone follow-ups. And it was quite late into David's placement, and we thought, well, why can't David do that and kind of, work within the service clinically, which he did. I think I just sat in the room, didn't I, David, just in case you had any problems or issues, but no problems or issues. Been very well trained by Marion, and so we were able to keep that service going for patients rather than them missing out on a week. David also managed to complete his GCP training while he was here with us, the good clinical practice training. So he had that recognised qualification to take forwards with him, which I think is a lifespan of 2 years before it needs to be updated. There was multi-professional contact with many different healthcare professionals. We worked very closely with one of the respiratory consultants, with the nursing teams, with our university teams who were also part of the study, the bigger study. So we were able to communicate with those particular stakeholders and maintain really good working relationships, and also show how useful a research placement is and the benefits of having a student involved. David also learned about the formal application of how to undertake a service evaluation or audit or research within the trust, right from start to finish, really, which I hope has been useful for David. I think so, in terms of the current roles that he's actually in. And also, obviously, David had chance to flex his wings with the further knowledge of statistical analysis as well, which he presented to very good effect in his final presentation, of which the respiratory consultants attended, our research teams. So it was quite a nice way to promote the department as well. Next slide, please, Hanan. Yeah, so these are sort of areas for further consideration, really. It was great to have David with us and his honesty. It's making sure that wherever possible, to have those opportunities to enhance clinical practice as much as possible. It is important to have a clinical component within the research placements. It ticks a lot of boxes, and obviously for the student, it still gets them kind of embedded within the clinical experience. Digital technology is here to stay. It's an incredibly useful adjunct to our toolkit of being able to treat patients. So David certainly got experiences of doing that. And being able to clinically reason, whilst you can't see the patient, still being able to carry out a thorough assessment and decide what plan of action is needed for that particular patient. The only thing we did find was sometimes it was making sure, because obviously you have set outcomes, learning outcomes to achieve with the unit. It wasn't the CPAF paperwork at the time. Our subsequent placements have used the CPAF paperwork for physiotherapy. But sometimes it was just a little bit more difficult, wasn't it, David, to match the outcomes of the placement to the learning outcomes. But we managed. I think had we not had that clinical component, it would have been a bit more difficult. difficult. Would you agree with that, David?
Yes, I would. I think it was a because obviously we're going into uncharted territory. We're sort of having to liaise with the university as well to make sure we're matching everything up and not sort of, yeah, trying to sort of associate the paperwork to the learning outcomes. Yeah, bit tricky, but I think you did a cracking job actually, trying to make it work.
Together we did, that's for sure. Next slide, please. Okay, so as regards the outcome of the specific objective, so the primary objective was to evaluate a new placement, primarily focused on research, audit or service evaluation. A paper was prepared as part of the clinical placement expansion project that I am more than happy to share, Hanan, if people, if people wanted to email me, I am more than happy to share. It goes through the whole project from the beginning to the end, including the slides that David presented as well. It was too hefty to present today, but if anybody actually wants to read the report, I am more than happy to share it and disseminate it if people would like me to. The secondary objective, we created an additional placement capacity, but also increased the toolkit of available placements for students at Huth to facilitate their learning, which we're very proud of. We've expanded our repertoire across the pillars. Hanan did a fantastic leadership placement and really made us recognise how important all 4 pillars are to professional practice, as I say, right from the get-go. Next slide, please. So additional outcomes. I think the flexibility was very positive, certainly for David. He was never anything but incredibly motivated anyway. He was a gift. And it really is important to have a student that really wants to get into research lock, stock and barrel. David was very experienced already. I know that, our usual students, probably even coming on to research placements, may not have quite so much experience. But it was good. It was good to, to give this a trial and see how things went. But the flexibility really was very positive, and it may be something that some students who may be at a certain stage of their training where clinical is not totally possible completely, they can still maintain those placement hours and still have a really good placement. Research skills, clinical skills, digital technology skills, all were developed, as well as the ability to manage your time. Obviously, I didn't spend 7.5 hours a day with David. David was able to organise his own time. We kind of mutually put our timetables together to fit around everything. And that's why it's so important pre-placement to have a think with your student when you're planning, how you're going to do it and how you're going to communicate as well. Involving the right stakeholders is always really important right from the beginning to make sure who you need to speak to, who you need to disseminate to, and who you need on board throughout those 6 weeks, really, in order to be able to make this research placement or any placement a success. Communication and presentation skills, had a chance to really kind of embed those into practice as well. And our NETS evaluation, thank you, David, was 100%. You'll notice in the CPEP report, if anybody does want to read it, we did do an additional evaluation to the NETS evaluation because it's quite generic, isn't it, the NETS evaluation? And we wanted to focus on some more specific aspects that were very relevant to a research placement. So we kind of put our own Google Forms together, really, of which we asked David to complete as well. And the results of that are also in the CPEP project report as well. So next slide, please. So lessons learned. Students are an invaluable source of innovative ideas, and as practice learning facilitators, it's really useful to get to know your students as much as possible, to begin to think, this is a strong student with an interest in something. Let's see if we can signpost them to possibly a placement that might be a little bit different. obviously liaising with our partner HEIs as well, who are very supportive. We've got to be realistic in our expectations, and obviously future placements is obviously tailoring the particular research placement to the student that is coming on placement, really. Share placement opportunities with our HEIs. If we've got actually a topic that we're able to talk about, or a topic that we know that we're wanting to base the research placement around, share it with the HEI so that they can think, this is something that this student really enjoys. I think it's useful that they know, so that they can begin to think about matching a student to that particular area, especially if they have an interest in it as well. I've already said about getting to know your students on placement. Thank goodness we had a good chat on placement 1, David, because that certainly helped this placement come to life. And make sure that you have those essential channels of communication so that your student has all the information that they need, and obviously that yourself as a clinical educator, a practice educator, is contactable. So obviously, of course, you have your set dates, but we also want, you know, if David needed anything, he had my telephone number as well. So, you know, I was contactable when David wanted to hear from me. So not only did we have our timetable contacted times, David had, you know, carte blanche to call me whenever he wanted to. And really the importance of planning for any placement, really, but particularly for this, making sure that you've got the correct digital equipment, the correct access to hospital systems, the correct processes in place to make sure that you can access those systems in terms of clinical governance, and what equipment's needed remotely. So David had a hospital telephone and a laptop, if I remember rightly. So we have student phones as well, obviously, because of COVID. We realized that, you know, students were doing telephone conversations as well. And the good thing is that we were able to, when the first telephone contact was made, I think this is what happened, didn't it, David? You were able to listen in. So Marion invited you to that telephone conversation with the patient, didn't she? So that you could learn what was being said. So it's making sure you have that level of communication between the phones so that you can have that three-way conversation. Obviously, the patient was aware that David was also listening and kind of, what's the equivalent of observing on the telephone, but just listening in, you know, to that particular conversation. Next slide, please. So we so enjoyed the research placement the first time, we thought we'd do it all over again. So this one actually finished at the end of June. I'm just going to talk very quickly about this one, just to say the differences between them. So this was a 3-to-1 module. So there were 3 students to 1 educator. There were University of Hull students, and they were second year students, undergraduate students, not MSc. Again, it was a 6-week duration, and our lead clinical research therapist took them all. The CPAF paperwork was used, which apparently was very straightforward to adapt, as the CPAF paperwork actually heralds that it can be used for any placement. And what we wanted to look at was hospital associated deconditioning. There was an observational component to the placement and a clinical component. So they worked with our rapid response team as well. So we were learning from our previous placement, how can we pop in that clinical input as well for students. Next slide, please. So our objectives for this particular placement, which I think finished the end of June, if I remember rightly, this year, was really on a trust level, to raise awareness, really multidisciplinary wise, of hospital associated deconditioning, and shine a focus on this locally, but also highlight that it was everybody's responsibility to help patients keep moving, really. Part of the research placement included a literature review that students undertook. So they wanted to look at how mobility declines when patients are admitted to hospital, and their general functioning. And this is what they presented at the end of their placement presentation, including posters that they put together and some other really useful information. We wanted to highlight the multi-system involvement to deconditioning, that it wasn't just an effect on movement, it was an effect on everything really. It also included an observational movement review of patients in one ward during the day, just to see how much they were moving really, so that we could share that with our multi-professional partners, just to highlight really how often patients were moving. We looked at many different functions. The students decided to use the Bartel index to not only look at mobility, but other aspects of daily living that really contributed to overall function of patients. And they used the cutoff points to determine the accuracy of the Bartel in terms of predicting discharge destination. So they looked at pre-admission and post-admission scores, and they obtained informed consent from patients. So we were only able to ask patients to help our students if they had cognitive ability and mental capacity in order to be able to do so. Next slide, please. So from their study, from their sort of investigations, they found the biggest declines were here: chair and bed transfers, toilet transfers, ambulation generally, bathing, dressing, and bowel control, particularly for the females. Next slide, please. I want to highlight this because I think one of the fantastic things that they did as part of their placement was they spoke to the patients, and they did a thematic analysis of why patients feel they might not want to move in hospital. This was the students, the sort of off the students' own bat really. They discussed as a group what would really be useful, so that we could obviously discuss with people at ward level maybe some measures that could be used to combat what patients are saying really. Patients obviously felt that there was reduced confidence, but one of the things that was often mentioned by the patients was they could see how busy staff were and they just didn't like to bother them. The gentleman always felt if they were a little bit more portly, shall we say, didn't want to sort of put extra pressure on nursing staff, for example, because they felt that, you know, they just wouldn't be able to handle them if they were able to, you know, to help them if they needed some help. At the time, there were some patients who were being monitored because they were quite aggressive, because of their condition. They were confused, and this frightened the patients and made them not feel like they wanted to get out of bed really, for fear of making situations worse. The environment was very busy. The toilets were too far away, which affected their confidence, even if they could walk. And again, with the staff shortages, they just didn't feel that they could bother people. And also, lots of things in the way. So trolleys might have been left somewhere, you know, like just treatment trolleys and things like that. Or maybe the floor had been cleaned, for example, but was now dry, but there was still the wet floor sign there and things like that. So even though those sorts of things, patients felt that knocked their confidence to actually get up and get moving. Next slide, please, Hanan. Yeah, so essentially what they did look at is the pre and post scores for the Bartel, to look to see whether it could accurately predict the patients when they were coming in, where their discharge destination would be. And they found it was a 66.67 accuracy, but they felt that the Bartel wasn't good enough because there was no discharge to a rehabilitation bed on the Bartel, they said. It was just discharge to a care facility. So they felt actually from the data that they got that the Bartel was actually quite good at predicting where patients would go post-discharge. The other thing they produced, because obviously they're wanting patients to get moving, was lots of material that they could put on notice boards in wards and things like that. So posters, exercises that relatives could actually do with their patients when they came in as well, even if it was just bed exercises, just to kind of keep that momentum going. and actually get relatives involved in the patient's care, rather than, you know, just speaking to the relative actually in the bed, for example. It was useful to feedback from the movement analysis, because most patients actually were spending most of the day in bed. And actually to present this data at the end, because we had some matrons from the wards actually come to the presentation at the end as well. They were very surprised to see this, and were very proactive, and we're actually going to take this back to the ward levels to communicate the findings. So in that respect, it was really quite useful in order to get those stakeholders, in order to kind of really highlight the fact that it is everybody's business to get people moving. But the information that the students produced as part of their placement was really useful. Next slide, please. Yep, so future plans for 23-24. We have 8 research placements that we've offered over the next academic year. I'm taking 2 in November and 2 in February, and our lead clinical research therapist is also taking the same amount of students as well. We're trialing at least a 2-to-1 educator approach, because it's quite nice having a peer to work with. We realise it's quite useful, and it's one of those placements where you can really benefit from having a multiple students in one go. Next slide, please. Brilliant. That's it. That's me come to an end. Thank you very much. If there's any questions that people want David and I to answer, whistle stop tour.
Thank you very much, Jane and David, for this insight to how did you initially the first placements that David was involved, and then seeing this 3-to-1 model that you just said that finished in June. And it's impeccable to see how the students has got like lots of power and enabled to really make a difference and come up with these results, and sharing it to influence better practice on the sites and on the wards. It's just amazing, isn't it? And just that reinforce that leadership is really part of all of the professionals' journey while in training and beyond. And I'm sure that these students and David themselves, they said like he's been taking the champion of research. So like this is exactly how powerful the journey and the experiences that you gain while you're students. We've got a few questions, Jane. I don't know, you want me to read them for you and Dave, or you're happy to answer it? So we've got so I think you've covered which year of student was the students on this placement, and then the 3-to-1 model that was just recently happened. You said about pre-registered. Are they year 1 or year 2 or year 3?
For the 3-to-1,
yeah,
they're year 2. So they were just coming to the end of their second year. Yeah, all from the same year. Yeah, all from Hull.
So from experience, do you think that that can influence the research placement at which year they're in, or from your experience, what's your opinion on that?
Yeah, no, that's a good question. I think you have to kind of, in terms of the output from the research placement, I mean, for example, David's placement, you know, David included statistical analysis, sort of probably a greater depth of analysis of data. Whereas for our second years, their output was fantastic in terms of materials that could be used to actually kind of make encouraging movement for patients on the ward better. So that is is a major consideration when you do have students on placement, and it's kind of gearing the research placement to the stage that the students are at. It's also really, really useful to know, and we have this level of relationship with both of our local HEIs, of the course content as well for any placement, really, to know what they've covered so far. Because it's very unfair of us to say, you're going to be doing this, you're going to be doing that, you're going to be doing the other, when they've actually done nothing of the modules, and expect them just to kind of, throw them into the frying pan, if you like. it is useful to have that knowledge, which we do. The component of all of the courses are shared with us, which is fantastic to have that from our HEI partners, so that we can match what they've done and maybe find a suitable project that means that they're not coming in blind, and have some knowledge behind it because of the modules that they've done.
Yeah, thank you, Jane. So it does, can be applied to different years at different modules, but that needs to be considered in the learning outcomes of what actually the experience will be to design it in Instant. We've got a question around the ethical approval process, and we know that how long does it take? Did you need to do, and you said around stages that you can maybe allow the students to take it from A to Z. So they are filling the form there. Did you have preliminary connections to ensure that this is a quick pace to be accommodated with a student's placement? Or can you talk us about this, and how did you manage to get these ethical approvals timely within the placement length?
Yeah. We kind of service evaluation. There was no need to actually. We already had the data. It was anonymized. Obviously, David was actually making the telephone calls with the patient, but the data was anonymous. There were no names on it anyway. In terms of ethics, there was no IRAS form to complete or anything like that. And all of the kind of documentation that we had to fill in, that David filled in for his, was to our clinical governance teams and to our audit team, so that we could formally register the project, and also give them an idea of what the outcomes were going to be. So we literally kind of put in everything in the. I keep saying the royal we, but I have to say it was David that did this, with guidance from us. But basically we thought of all the different bits of data that we would need to actually kind of have a look at, and included that in our CG1 form. So this is the clinical audit form that we send to our clinical governance teams and audit department to make sure things are okay. And then just wait for the ability to be able to start it, really. It didn't take too long. I think there had been some communication that we were thinking of doing that before. So pre-placement, there was some discussion with our clinical audit department to make sure that this could be dealt with as a matter of urgency, because we had that time limit, I suppose. But the other thing we did talk about at the end, but we felt was probably going to be too much for David, because you quite enjoyed the project, didn't you, David? And whether there was a possibility for David to continue in an honorary capacity, so to look at sort of honorary contracts. But we felt that, you know, David was still working his way through his MSc, really, just because of the possibilities that could have come from his research findings. But we felt, you know, it was probably a bit too much, really. But in terms of the data that we had to access, there were no ethical concerns, really. And that is a consideration pre-placement in terms of IRAS and ethics applications. Yeah, it's quite a consideration. But of course, with research placements, it may be that it's not the end of the research that you're doing in one placement. It may be that someone passes the baton on, so that it goes to another team, which we actually did in a project placement. So we had some students who were putting together information, really, to teach students how to take telephone, you know, to do telephone conversations, that actually lasted over a few placements, and we had a team of 4 students for each of those. And it was really useful because that had a huge leadership component as well, because we chose the leader of the team every week, so that they could actually organize the team and obviously organize what they were doing. Yeah, but in terms of ethics, we were able to put everything in that we felt we needed from a clinical governance side. and get the okay from the clinical audit team and from the relevant clinical governance teams as well to make sure we could hit the ground running, really.
Thank you, Jane. I guess you've answered some of the questions that were posted while you were doing the presentation and now. Do you think that staggered placement research would be a good idea, that if you couldn't do the research from A to Z, that you build up stages where students can hand over from one cohort to the other? Is this a way, if the timeline doesn't allow the students to take it all through the stages?
Definitely, Hanan. Yeah, definitely. And I know has been done in some other areas as well. It's knowing when you reach a certain stage and making sure that you complete that stage, and then it's in able to be handed over to the next set of students. And also, like you say, it might not be that a placement will start exactly after that other placement has finished. So it's making sure that there's enough material at a stage where, a placement, whenever it's going to happen, is able to be passed on and have the relevant people there in order to be able to pass it on if it's not the students.
Thank you. Yeah. I hope that the audience, thank you very much for being here. Your camera and mics are all enabled if you wish to speak your question instead of posting it on chat. So do please go, ask for fire your question, really. I know we're over time, but we just hold on if there's any questions coming from the audience before we close. We do welcome all the feedback that you can use the QR code or the link that is posted or through the slides, really. I wonder, David, if you can come, if you have any final say from your experience, and how would you encourage placement providers to offer research placements in your opinion?
Oh, it's a hard question, that. I think it's something which should definitely be offered out. I think it's not going to appeal to a good portion of students. I think it's something which can perhaps be offered as a maybe as a sort of volunteered position, I think, because we're quite often also we're offered, we're told what our next placement's going to be. I think it'd be quite good for students to be given the opportunity, if that's something, a career that they potentially like to consider. I think it's something it's good to offer. I think also to offer some degree, perhaps, of, I appreciate, due to ethics and other constraints, but it's good to sort of try and tailor something within that topic area to sort of what the student would like to do. But I think overall, I think it's definitely beneficial to my career now. And I'm not saying that just for everyone's benefit. It definitely has helped, and it was a good opportunity to, like I said, it's a good opportunity to get a feel for research within the NHS environment, which you won't necessarily get from the typical academic environment. And so I think it is certainly a superb opportunity, and I think being at a teaching hospital, that was sort of exemplified. Yeah, no, I think it's fantastic, and I think the Huth team were superb and looked after me very well, especially Jane and Angela, who did a lot to put up with me. So, but yes, no, I think overall it's a superb opportunity. But yeah, I'm happy to answer any questions as well from a student perspective.
Thanks a lot, David, and best wishes from now on with your career. You might be lead researcher somewhere in no time. Jane, thank you very much for leading on this webinar. It was really insightful to hear what you've done and the 3-to-1 model that recently you've finished, and your plans ahead to do more of them. And thanks for offering the report. So if I did say in the chat that we will post this report alongside the post-webinar communication that we will be sending out. So that would be perfect. Do you have any other? We don't have any questions or hands up. Do you want to have any final says? And do please encourage you to fill feedback for the webinar, because we always try to improve on these and help us build on them.
do you want me to send you the Word document, Hanan? Because I know where it is. I can probably get to it quicker and then just email it to you, shall I? Or
Yeah, can
you know,
email it
the
to me
CPAC
and I can
project.
send it through. Thank you very much. Thanks,
Yeah.
Jane. Thank
No,
you very
you're
much for
welcome.
this.
You're welcome. And just to say a huge thank you to David and hearty congratulations on such an early start to the career, but such a fantastic position to already be in. I'm very proud of you.
Well, thank you so much. Well, you were definitely a huge help to the journey.
Thank you very much.